welcome for joining this. And today is also the one of the first days, so we might just experience any kind of connection abnormality, difficulty. So we are going to take care and wait and also take patience to let our colleagues to join. So I'm going to start slowly, and as was last meeting, the virtual online lecture series. So as was last one, I'm going to invite any kind of question. However, for the time's sake, at first I'm going to ask Dr. Gil and Dr. Asmar. Dr. Gil is a master student who is also a first-year resident, and you might feel the next generation and young, the nuclear medicine physicians of our future of Asia. You might feel the same as Dr. Gil. He has just started. And Dr. Asmar, in case of Dr. Asmar, he is also a junior staff in his own institution, but he took the risk to come here a second time in Korea to become the PhD student by the support of by being elected and selected by for the Seoul National University presidential scholarship. So he's pursuing the PhD course. He already spent two semesters, and he showed a quantum leap. From our point of view, he is now one of the key members of our research, doing brain image analysis, and also please wait for the results. But the keyword is radionuclide cystostomograph in mice and rats to unravel or elucidate the importance of the waste disposal from the brain by lymphatic and lymphatic. This might sound like a really kind of alien language, but we are doing that kind of research by the support of the Korean National Research Foundation. They recently approved this study. Anyway, Dr. Asmar is a well-established the nuclear medicine physician who are quite knowledgeable about the clinical side. But during this lecture series, as an introduction, I'm going to tell you how to teach or persuade or enlighten our colleagues. Colleagues means the clinician colleagues. We need them to be able to and to need to want to use our nuclear medicine technology for evaluation of their patients, and also for diagnosis and as well as the treatment. So whatever they propose, we need to communicate with them very well. And I'm going to just announce a very good the news. Professor Edmund Kim, who had been in the United States almost 4 decades as a professor, 3 decades in MD Anderson Cancer Center in Texas, Houston, and he was in charge of at first PET, and then MRI, and then combination. And recently he moved to, after lifelong the contribution to MD Anderson Cancer Center as the chairman of the diagnostic imaging, they established a new department, as I heard, several decades ago for him. And he's a pioneer in PET and radioimmunoscintigraphy, and clinical PET and radioimmunoscintigraphy. And also he was a founding member of the MRI application to a clinical situation. And he had been the invited professor for the last decade to Seoul National University and hospital. And he was locked in UC Irvine, University of California, Irvine Hospital. He has a title there as a professor because of the situation of the COVID-19 in the United States of America. Until recently, he was locked, but recently, meaning on Sunday, last Sunday, he arrived, and he's self-quarantined for 2 weeks. He's going to join our department for the next 4 months as an invited professor. So I asked him, and he kindly agreed. And you are looking at the lecture series, distinguished lecture series in a lecture series, organized and coordinated by myself. And this is a distinguished lecture series by Professor Edmund E. Kim. And I asked him, and he gave me the title there. And from September 23rd, he's going to deliver 7 lectures, distinguished lectures, and which will be moderated by the recently the entitled professor, junior professor, Dr. Soo. Dr. Soo, Professor Soo is going to moderate the series with him, and the Professor Edmund Kim is going to deliver his lecture, and then he can just give you the chances to ask him anything. He's mostly known, the best known as a author of many textbooks since 70s and 80s. So when I was a resident, I learned from his textbook, and finally, recently I co-edited a textbook from various publishers, including Springer, and he's going to give you the lectures and the prostate cancer and that kind of, and finally tumor genetics. His lecture is going to cover from the mostly the clinical parts, but his expertise both in MRI and PET will give you a chance to look at how to use our discipline to help people and patients. So today, my topic is a kind of an introduction. Last week, we dealt with how to use microdose SPECT based on base. So I emphasize the prevalence is important, and this is already well formulated as a triage of the patients when they visit outpatient clinic or when they were supposed to have a coronary artery disease. Then how to let the patient navigate all of the complicated system of the many diagnostic tests and the treatment modalities. Of course, the cardiologists and cardiac surgeons, they decide. However, it should be based upon the evidence. Evidence meaning science, and science is going to a real real firm support for nuclear medicine, and we need to be quite knowledgeable about the basis of nuclear medicine in terms of science, and then we can be respected. We can have a confident support from the clinicians. And if we can build a well-established relationship with the cardiologist and cardiac surgeons, then it is the best way to help people, and it is the best way to pursue our expertise through the ever-changing the environment or milieu of clinical practice. So today I have already uploaded here NM portal, everybody knows that, and lecture series here, and you can find the information regarding Tenkoika lecture series here, how to use, and then revised schedule is already there, and the same Zoom is going to be used, and Zoom address is going to be used, and also at the forefront of the web page, you can click on YouTube, and everything is recorded. And as I just told you, this can be viewed on YouTube. So everything is they can be replayed, and or you can choose this option because YouTube is going to give you the option play the double time. I mean the faster. So I think you'd have little time to learn and more demand from the clinics to learn. That's on-site learning, but it should better be complemented with some new information. And the talk, my lecture, or my presentation is based upon my 3 decades of experience with communicating with the students, medical students, and also my colleagues. My colleagues, the communication with my colleagues used to be very brief. They ask and I answer immediately with very short sentences. But with that kind of communication, finally they trusted us, and they kept using our technology or methodology to help their people, their patients. So today I'm going to use some writing, and it's kind of using a whiteboard here. I drew some just a couple of minutes ago. However, the entire the slides is just 38 slides for 2 hours and half. So now I already spent 14 minutes. So I'm going to ask at first Dr. Gil and Dr. Asmal, if you just kind of have a goodwill or favor to save their embarrassment, then even you can just kind of unmute your the video or the audio conferencing system, unmute your computer, Zoom, and then you can even answer to any kind of my questions, or you can ask questions, just kind of interrupt me. I have prepared 40 the slides. The last week I prepared more, but I could not cover. Why? Because actually I covered all, and there has been no need to cover. Why? Because the the questions that I asked to Dr. Gill and Dr. Asmar, and their answers and their kind of steps to improve their understanding how to teach their juniors, meaning the medical students, and how to teach their peer colleagues. In case of Dr. Gill, he's a resident and he has colleagues in other departments like internal medicine or the cardiothoracic surgery. Those are much more important, and we need to just improve our communication skill based on our clear, succinct understanding of our technology. Okay. So today's topic was supposed to be about the brain blood flow and flow reserve, which had been the long time used in our department. However, it was not the case when I started my the career as a nuclear medicine physician in 1990. And we established this technology by the help of the Japanese colleagues, and they kindly helped my predecessor, my teacher, Professor Soo Lee, back in 1994 and 5, by giving him a tested dose of vials of acetazolamide, which were not available in my department and as well as in my country. And after that, we have taken a long road to establish. And then our clinician colleagues really in a versatile way use our acetazolamide Brain SPECT, and they have become almost the globally best surgeons who successfully managed cerebral vascular disease patients at first in children, and then finally in adults. And recently they stopped using the acetazolamide Brain SPECT for children. It was the kind of a shocking story for you. However, I'm going to explain today. Now, it was supposed to be acetazolamide Brain SPECT, but the continuing the previous weeks, the topic, the how to use microdose SPECT, based on the clinical, based on evidence, which is also based upon a theorem, which is well known to the statistics and the mathematics and also social sciences based theorem. And so the brain blood flow and the myocardial blood flow, it looks the same, but it is different, quite different. So I'm going to just emphasize, and I'm going to make it strong for you to understand the difference, so that you can understand the difference of the adenosine myocardial SPECT and acetazolamide Brain SPECT. Okay, so today's topic is like this. At first, as is well established in the physiology, myocardium versus brain. It will take almost 1 hour. And this is going to be a question and answer. And Dr. Gill and Dr. Asmar, please expect any kind of question. And I'm going to just kind of let you know that the Dr. Gill and Dr. Asmar did not have any rehearsal with me. So for them, it is a kind of a question out of surprise, out of nowhere. So So please keep this in mind, even though they would be a little bit embarrassed and not to find the correct answer, but sometimes it is not important to have the correct answer, correct way of thought. And then radiopharmaceuticals and physics, and then acetazolamide challenge, and then the most important for nuclear medicine physicians are going to be the when to use acetazolamide brain SPECT, and which is quite a rare information. Why? Because even though the European colleagues has established acetazolamide brain SPECT, and then they just kind of gave up to use, and they just kind of discarded. So our Japanese colleagues, they have used it, and finally they taught us, and it prospered in Japan and and Korea. So the first question is this one. Just a little bit get relaxed, and please refresh your knowledge about the normal blood flow. This kind of table, I can use this table with, I could use this table with my students for the almost 2 decades. And they were, when I ask any component of this one, our students were really embarrassed, and they could not find the correct answer. And finally, they were ashamed, and they were impressed by the nuclear medicine physicians, the really ambidextrous knowledge of handling this kind of physiology. So Dr. Gill, I used to ask the medical students, how much is the whole body blood flow? And
Above,
yeah,
5 liters.
Yeah, so you say the 5 liters. And then I would just ask you again, the same student again, then how much is the whole body blood volume? Whole body blood volume. You have a body weight of the 70 kilogram now, you adult. Children are different. However, I'm just kind of, why? Because coronary artery disease is a disease of the aged people. 70 kilogram. Whole body blood volume. How much is it? You just read it.
Yeah, I think blood volume is 5 liters, and
yeah, 5 liters. And interestingly, whole body blood volume was measured in 1960s using the Chrome 51 labeled RBC. RBC volume was measured by just a dilution principle, and then considering hematocrit, and then 40% of hematocrit, and 100 over 40 was multiplied to the 2 liter per 70 kilogram, and then they finally got the 5 liter, and the male and female, and then I mean the men and women have different the blood volume because of their body habitus is different. Kilogram, the body weight is different. So I intentionally put a wrong one here, because every student is saying like that. Whole body blood flow is 5 liter. No, 5 liter per minute. It should be flow. So I don't think the medical students, even nuclear medicine physicians, at beginning state, we don't know. We are not quite concerned about the liter per minute and the difference between a liter per minute and liter. However, when I just put per minute, and then automatically it's 1 turn per minute. very excellent students are coming among my the student groups. They quite rarely, and some of the students are replying to my question like, I asked, how much is the whole body blood flow? And he or she asks me, whole body blood flow, the professor, you asked us, how much was the whole body blood flow? And the most brilliant student told me that, as the answer to me that, then does he need to just include pulmonary circulation or not? So, is it pathologic situation? No, I just told them the normal person's blood flow. And he answered that if a patient, if a subject does not have a shunt, and if we are interested in systemic circulation, excluding pulmonary one, then it is going to become left ventricular stroke volume multiplied by heart rate. And then, according to his crude calculation, it's almost to 5 liters per minute. That was the best answer I heard. Our students sometimes we are really astonished by their excellence. So I answered to him, why don't we just take the change of the seat? You came to become the professor. I would be just kind of an observer. You please teach your colleagues. So we all laughed and moved on. So whole body blood flow was like that, and I'm just I was just trying to make you memorize and remember how. Why? Because according to my second question, we don't care usually the whole body blood volume. Whole body blood flow, everybody knows that. It is just kind of a left-sided cardiac output. Right-sided cardiac output is the same. Okay. If you say the pulmonary circulation is complicated, pulmonary artery is supplying most, and there is a systemic circulation which is supplied by bronchial artery. So that's kind of a delicacy and refinement of our knowledge. But what I'm trying to emphasize is 1 turn per minute. And then afterward, it is just kind of the arithmetic problem. We make images for the brain perfusion or the myocardial perfusion. It is going to make a kind of a milliliter per minute per gram tissue or the per voxel. That kind of information is used to be just kind of presented on the screen and on kind of printouts or information given to them. So the next question was the per gram tissue, whole body blood flow, average per whole body. The per gram tissue was just kind of, if I calculate, just 0.07 milliliter per minute per gram. Then Dr. Asmar, and in 1 gram of tissue, how much blood is there? Please calculate. Oh, so time.
Like as it's shown over there, 0.07.
Yeah, so you hesitated. So you know, the some of the students, they calculate again and then came to become wrong. So I wanted to emphasize again. So per gram tissue was the same here. Then the question mark is going to be changed. Well, change it again. So then, the how many passes per minute per gram tissue, Dr. Asmar? How many passes?
How many pass? It's
Yeah,
like
yeah.
heart rate. It should be the heart rate.
No. What I'm saying is just, okay. I would have confused with using a not the correct English. So entire, I'm just drawing, entire body has a 5 liter, and left-sided cardiac output was 5 liter per minute. 5 liter is turning in 1 minute. If we just kind of extract 1 milliliter or 1 gram, if the specific gravity is one entity, and then here 0.07 milliliter is blood in arterial and capillary and vein altogether, and then in 1 minute this is passing once. Okay, the same as here. Then Dr. Gill, I have a question. In your expectation or in your knowledge, according to your knowledge, acquired from PET, myocardial PET, blood flow per gram of myocardium, how many times in myocardium over whole body average? So everyone knows that the myocardium is going to use more blood perfusion. So how many times do you expect? How many times?
About 3 times.
Yeah. So you are so humble. But according to the PET, this is known. This was acquired. The number figures were acquired 1985, published in Circulation, and it's interestingly used to be almost 10 times. You know, by the common sense, our medical students, almost all of them, they expect similar one. They think that the myocardium is moving every day, every night, during we are still alive, before death. So they expect correctly, and which was really, really a surprise to them and to me too. So meaning, if you just extract 1 milliliter of 1 milliliter and 1 gram of myocardium, and if myocardium, the blood, the blood in the blood vessel lumen is or 0.07 milliliter, and in 1 minute, 10 component is passing. So it's how many passes per minute? So this reminds me your previous question, previous answer. So it's just a 10 per second. And then I just kind of agitate our students, like Dr. Asmal. Then we can say that this is not always. Okay, and then they immediately know that yeah, stress physiology is being discussed, and during stress peak, this is different. So Dr. Asmal, we know that how many times at stress peak, exercise peak, over rest in myocardium. How many times? We all know that. It's just kind of if you don't remember, then just kind of expect, guess, speculate.
Double.
Yeah. So you were correct. Why? You were thinking about you just kind of consider the situation of the aged people. Why? Because the cardiac physiology is important for aged people. For young people, no problem. However, in case of young, we all know that the 3 to 5 times. How? It's kind of according to the maximum heart rate, which is 220 minus age. At the age of 20, the maximum heart rate is 200, and then cardiac output is stroke volume multiplied by heart rate. That heart rate is almost 3 times, and we all know that the myocardial stroke volume is increased at the peak of exercise 20%. So 3.6 times is normally and naturally acquired. Then how about the 5 times? Another 5 times. How about the 5 times? So finally, there is a vasodilation, meaning in case of exercise peak, it is not going to be 0.0 milliliter per minute. It is going to become even 0.12, 0.12, 0.12 milliliter per minute. How do I know that? I was involved in the study, cardiac PET study, using oxygen 15 water back in 1993 in St. Louis. I tried to learn clinical nuclear medicine using PET, and they taught me, and they let me do this kind of analysis, and I found that, oh yeah, blood volume is also increased. And then cardiac heart rate is easily acquired by just EKG monitoring. So I could understand that 3 to 5 times blood volume here. Then how many passes per minute? It's almost 3.6. How? That's 3.6 per pass per minute is in addition to vasodilation, because of the vasodilation, because of the increase of the velocity. Velocity meaning by the support of cardiac output, which is stroke volume multiplied by heart rate. Heart rate is depends upon the patient age. Why 2 is correct is as much as 2 is correct is if a patient subject has a age 60, then maximum heart rate is and baseline heart rate is increased 80, then 2. And if we just kind of combine vasodilation 1.2, then 2.4. So 2 is correct for 2.4. So we know these things very well, but we do not use that information when understanding. And then here, I draw this again. And why? And how to explain this to clinicians and students. Now you are familiar with this drawing. 1 gram of tissue, and we put radioactivity here, and then MIBI uptake or Hmpa uptake is going to mean blood flow. But everyone knows that blood flow is milliliter per minute. How to get rid of minute? It's just kind of outflow is the occluded, interrupted. How? 100% clearance or uptake. And best one is microsphere. Everyone knows that we are using microsphere for hepatocellular carcinoma. Yeah, so that SERT, the bead or glass microsphere, is used for hepatocellular carcinoma to block the new vessels of the hepatoma. Then the inflow is all captured by the tissue. So we hope the HMPO and MIBI both are 100% captured by the tissue. They call it cleared. But we all know that the MIBI is taken up only 60%, thallium is taken up 85%, rubidium is taken up 85 to 90%. Then, but what about the H2O, water? Water is taken up and washed out, taken up and washed out. And so we need the kinetic study. So next week's topic is so naturally going to become the tracer kinetic, which I understood. Trace kinetic is used to be considered as a position belonging to the medical physicist. No, actually tracer kinetic understanding is one of the main, the core concept of the nuclear medicine, which in which we need to, with which we need to be very familiar, and by just kind of ingesting, digesting all that kind of kinetic understanding, information, then digesting it and making it with the natural language, and then explain to our clinicians, and they start to respect us. Not just kind of giving them the results. This patient has no evidence of bone metastasis and no active bone lesion, so they don't care. They can become very much familiar with that kind of receiving report. They can even do the same, but they don't understand the basic knowledge behind the bone uptake, osteoblastic activity is taking up the phosphonate, and that MDP is taken up, and so we need 4 hours, 3 to 4 hours for why? Because it's not our fault. It's osteoblastic, the bone activity takes time. So FDG is taking 1 hour based upon our tracer kinetic analysis, the understanding. So that might be. Today, I'm just emphasizing this one. And, you know, interestingly, Dr. Gill, so we have flow and flow velocity. By just looking at this drawing, would you please explain the flow, the relationship of flow and flow velocity?
Flow velocity is determined by flow and area surface.
Yeah, that's the kind of usual interpretation by our cardiologist colleagues, which confused us. So every student is coming to my the department for learning the nuclear medicine. They have been already confused. They already have been. All of them have been made confused about the difference or the sameness of the flow and flow velocity. So I needed to correct them, and finally they could understand correctly. And flow velocity is usually measured by the cath lab or using the echocardiography. They don't care area. However, we know that the area is increased, not just the conductance vessel area or conductance vessel diameter. What is increased, as I just told you, when you Okay, let's move on. So long story short, we nuclear medicine physicians, we just emphasize that the flow has the unit of milliliter per minute. That's volume per minute. Flow velocity is centimeter per minute, which is kind of a distance term. All right. Echocardiography Doppler effect is going to give us only the distance. And echocardiography results are usually, what I'm saying is just intracoronary Doppler study is going to give us the millimeter or centimeter per minute. And also the catheter can give us this kind of information. But we need area. So square centimeter. So flow is area multiplied by velocity. If you use velocity only, then you're ignoring area. But using cardiac PET or brain PET or the myocardial SPECT or brain SPECT, we are looking at the flow. The volume is entering brain or myocardium and then taken up 100%. Then radioactivity is proportional to the blood flow, and we don't care the velocity is increased or the area is increased. So that's the reason why, in case of exercise stress SPECT, we do increase area and velocity altogether, as I just told you, vasodilation and also velocity. But in case of adenosine, we do use only area is increased. Area is increased. Vasodilation meaning vessels are dilated, so input is increased. When you do the adenosine injection, cardiac output is not increased. Rather, it is a little bit decreased because of the unwanted systemic vasodilation. So how to compensate that kind of vasodilation? Patients are sometimes experiencing a little bit of increased heart rate. Heart rate increases systemic vasodilation and myocardial blood flow is maintained. So there was a story. If it is not the successful, then we say that it's coronary steer. Anyway, so flow velocity. So the last question with this kind of drawing, flow velocity. Dr. Asmar, in heart, during stress exercise here, stress exercise, flow velocity, according to my explanation, is increased or the same?
See.
Okay, increased. Why? During exercise, heart rate is increased, stroke volume is increased a little, combining, cardiac output is increased. How much? How much is 3.6? Yeah, 6 times, and then it's increased. What I'm trying to emphasize is, what about brain? Brain has a internal carotid artery and vertebral artery, and sacroiliac and posterior cerebral artery. Internal carotid artery is giving birth of the middle cerebral artery and anterior cerebral artery. There are perforating branches supplying here, deep gray. And then brain stress situation is activation. Brain, some area of brain is activated, and it is we all know that that area is receiving higher blood flow. How much is going to be disclosed at the end of the lecture. But in this case, flow velocity, is it brain's when during stress, brain activation, when cognitive function is running on, and then brain is doing some the works, then flow velocity, is it is it the same or increased? Dr. Asmar.
Same.
Okay. Yeah. So while Dr. Asmar is thinking, I can just let you know for everyone. The nuclear medicine physicians at the beginning, we want to be a very good nuclear medicine physician, which has quite a knowledge about the physiology of our organs to be studied, and based on that those knowledge to communicating with our clinician colleagues, so that we can just be a help to their clinical practice. However, this is not easy. Okay, so even though the answers that I just explained, I sound like a little bit the authoritative, dealing with the correct answers. And once you listen to my just kind of the declaration or interpretation, you might just concord with me. Oh, it's correct. However, it takes time. You need to think about it again and again and again. By just looking at your myocardial SPECT image or brain SPECT image, the myocardial SPECT is quite prevalently used all over the world, even in developing countries. And however, brain SPECT is not the case. So if you consider the brain the same as the heart, it is entirely wrong. Why? Because for brain stress study, we don't let the patients exercise. We use instead cerebral vasodilator, which is called acetazolamide, and the flow velocity is not increased. Heart rate is not increased. When you think something, your heart is not just kind of palpitating. Your heart rate is the same. You just stay calm, but you think about something. So based on this knowledge, now back to here. In case of the coronary artery having showing the area of 50%, remaining area of 50%, so we call this 50% of area stenosis, or sometimes 90% of area stenosis, atherosclerosis is occupying the 90% of the lumen and 10% is patent. And then flow is average multiplied by velocity. Area is decreased to the 1/2. The velocity can be increased twice easily. Then how? How? It's because we all know that here is a pressure is going up and distal pressure is down, and then this because of the pressure difference, and the velocity can be easily. Then 10% remaining. Flow is like that, area is 1/10, and velocity should be multiplied 10 times. Is it possible? Dr. Gill, 90% of lumen area stenosis and 10% lumen is remaining in coronary artery conductance vessel, then large artery, then 10 times of the compensation by velocity. Is it possible?
I think it's not possible.
Okay, then my the next question is, area 90% of stenosis. Stress at rest. Perfusion, myocardial perfusion, myocardial MIBI uptake would be normal or abnormal. So according
Maybe,
to your,
maybe normal.
you chose what?
Maybe
abnormal?
normal.
Maybe normal. But you just said it's 10 times impossible. Is it possible? You said it's possible 10 times of velocity increase?
No, impossible. Yeah.
Impossible. Then, however, you said based on your other knowledge, 90% of area stenosis at rest, myocardial uptake, MIBI uptake is normal, correct?
Yes.
Then it is kind of paradoxical. And would you explain how? Then how? How 10% is supplied? 10 times are supplied by for the compensation of the 1/10 of 90% loss of the area. How? Dr. Asmal, would you help? How, if Dr. Gill is correct, then
Vasodilation.
Vasodilation, but you mean that atherosclerotic areas are dilated 10 times like this?
That actually doesn't happen.
Yeah, doesn't happen. So doesn't happen. That's Dr. Gill told. So do you agree with Dr. Gill? 10 times is impossible, but you know, the area 90% of stenosis usually is showing the normal MIBI uptake at rest. Then how can we explain? How can we explain? So there was kind of a homework for our medical students. And after 1 week, half of the students were correct in their answer. How? At first, they told me its problem was the chronicity. Chronic obstructive stenosis is making the saving time for the myocardium to adjust. How? Most of them are saying the collaterals. If 90% of stenosis occurs abruptly, no way to compensate this one. However, we have, even though the myocardial coronary arteries are the end arteries. End artery means in normal situation they don't have any collateral. However, in case of this kind of a critical situation, myocardium, coronary artery, and other coronary arteries are trying to help the adjacent area. So I found that based on this kind of the reasoning, my students have sent me the usually wrong answer. They chose this one, but we know even 90% of stenosis, myocardium, MIBI SPECT is usually normal. So if I just put here the correct answers are this one, this one, this one, and that one. So that's a very simple fact, but not always. If everything is like this every time, then there is no need to do myocardial SPECT. Because of the acuteness and chronicity, and then whether there is a well-developed collaterals or not, and triple vessel disease, all the vessels are aching, suffering from the deficiency, so they cannot, and they would have been acute event and coming back. So many, and then I just told you about the only the 10% here. Some of the stenosis like that. So we need to just look at the coronary artery angiogram. So if your institution have a PACS system, you please try to persuade your cardiologist to let their coronary angiogram upload it to the PACS system. It happened only 17 years ago in Seoul National University. Before that time, only cardiologists knew how the coronary artery, the structural changes are there. So they did not disclose. Actually, they did not hide. We could not just get an access. 2003, PACS system was first installed, just a chest PA or the simple. And finally, now we have everything. Endoscopic findings and echocardiographic findings, and also coronary angiography, and even the TFCA, carotid angiography, everything is there. So now it became, so that's the summary. I'm going to, after explaining this, I'm going to stop here and take a 10 minutes rest. So that one slide has everything here. Myocardium, coronary blood flow at stress 3 to 5 times. For everyone, no, for only young people. For aged people, it's decreasing. Systemic blood flow increase as at exercise. In case adenosine, no. That's a very important statement. However, in contrast to myocardium, brain, gray matter perfusion is just 1.3 to 1.7 at maximum. That maximum is induced by the acetazolamide injection. And systemic blood flow is the same. How acetazolamide is kind of letting the brain tissue produce carbon dioxide the same manner. However, the carbon dioxide in brain is not converted by the inhibition of the carbonyl anhydrase by the pharmacologic action of acetazolamide. Or if you prefer, you can use the anesthesia machine to increase the CO2, the pressure, partial pressure of the CO2 in the brain by just rebreathing, or oxygen, carbon dioxide, the pressure and content increased. Okay, so I have used only 7 slides, so I'm going to take the break, and after 10 minutes, I'm going to move on here. You have already my slide here from 14 to the end. Okay, and before starting at 1:15, 10 minutes later, 1:15, I'm going to take questions by just chatting. During the break time, you can ask me anything. If I knew, then I would just kind of immediately answer. If I don't, then I study hard. And next week, I can just give you answer, or I can confess that I could not understand. Your question was correct, but I could not find the correct answer. Okay. See you 10 minutes later. thank you for coming back, and I wish at least one per country to become the quite knowledgeable of this kind of information and the method to deliver our understanding to your colleagues and your next juniors. They continue to maintain the doctrine of the nuclear medicine. Nuclear medicine is just not reading, not just the reading the images. All of a sudden, for some while, we made our discipline to look like radiology, which is reading images, complicated images with a very good pattern, the recognition by the human intelligence. However, this is not. Our images had been a little bit kind of ambiguous, but it contained really important physiologic information, which is based upon the physiology is the most core concept of our nuclear medicine. And to elucidate the physiology, we used to use the radiopharmaceutical, which is tracked and cleared even at single circulation by the tissues. If that tissue was supposed to be myocardium, then that giving us the myocardial perfusion imaging, which was once called MPI, and giving yielding the information regarding information of the resting the blood flow, and also the stress blood flow. And because the MIBI is supposed to be it's just trusted to be taken up by the myocardium, the same 60% of single pass extraction, and with the increased blood flow of 3 to 5 times in young, and 2.5 times in the old aged. So we can just kind of interpret that rest and stress imaging, which is normalized to the maximum of that count. So even though stress perfusion defect is having the rest, the blood flow at the rest, we tended to, or we were kind of eluded. It was kind of elusive that the defect is defect has been made. No, actually that is not the defect. So the resting blood flow is maintained. The only problem was the blood flow increase was not achieved after the exercise stress. That was the case. Anyway, let's move on to the brain. Brain is the second important organ. Why? Because the heart disease is sacrificing so many people, and then brain disease, and then tumor. So that's global disease burden. So like MIBI and tetraphosphine, in case of brain, there have been for a long time the radiopharmaceutical, which is called ECD and HMPAO. So I'm going to try to explain why we are not using ECD and we are using HMPAO. So to be fair, I'm going to explain the first ECD. Technetium ECD looks like this here. And there the whole body distribution is like that. And that kind of information is in our older journal, and Journal of Nuclear Medicine, 1989. The first total body image was published, and please look at that. And after a while, 2 hour and 4 hour, at first it's taken up by every organ, liver, kidney, and lungs, and then wash it out via intestine. And kidney too. Why? Because you are looking at the bladder. All of us are nuclear medicine physicians, and we are quite familiar with this kind of image, even though it's not tomography. And also, 1990, in the Journal of Stroke, they measured regional cerebral blood flow using probably using using MRI. No, at that time using PET, and then the ECD percent injected dose per gram of tissue, the percent uptake of injected dose, the percent injected dose of radionuclide, the radiopharmaceutical taken up in a gram tissue. So it looked a little bit kind of the proportional. And brain blood flow here, you might just find that cerebral blood flow is 1 milliliter per minute per gram to 3 milliliter per minute per gram. It looked like silly to me. Why? Because here, this is the kind of final information we've established and they listed in the textbook. Gray matter blood flow is milliliter per minute per gram, 0.7 to 0.9. It's the same as the resting myocardium. Dr. Gill, you would be now familiar. I can just kind of ask Dr. Kaim or Dr. Kwang Hien or Mr. or Miss Miss iPhone. Somebody used the name of the iPhone instead of, or Dr. Harahap, or Dr. Alexander, or Dr. Minnat, or yeah, Da Nang Nuclear Medicine colleagues. They just kind of entered as a class, or yeah, Dr. Jasmine. Yeah, so long time no see. Okay, so and also Dr. Huen Tong. So I actually really want to kind of proceed this session as an interactive one. Anyway, gray matter 0.7 to 0.9, and interestingly, white matter the blood flow is much low, 0.2, 0.3. So when you read MR perfusion study, you are going to immediately be reminded our the measurements data, and sometimes it might have been changed, revised, because there had been on previous the study, they have used older PET machines having a full width half maximum, which is equivalent to the resolution. The full width half maximum was almost 10 millimeter, meaning the brain, if brain is a gray matter and white matter is mixed, and so at first, at the beginning, they could just say only the average. So 0.5 milliliter per minute per gram is kind of the mixture of white matter and gray matter. Gray matter is convoluted. The white matter is intermingled. So you can just remember 0.5 milliliter per minute per gram. And brain has the weight of 1.5 kilogram, and entire brain has a 750 milliliter per minute. And also, this is a 12.5% of cardiac output. Now we all know that the cardiac output is not 5 liter. Cardiac output is 5 liter per minute. So 5,000 milliliter per minute. So you can just easily calculate. And then what about HMPAO here? HMPAO has a interesting chemical name, DL HMPAO. DD and LL forms are there. That's kind of so you should be reminded of the stereoisomer and enantiomer and racemic the isomer. So I forgot the exact exact kind of definition of those. Anyway, in case of the HMPAO, if you are interested in synthesize the HMPAO, but it is commercially available. And here, CVF was measured by xenon. In older times, they have used the xenon, and xenon has given here milliliter per 100 gram per minute. So as I just told you previously, the cerebral blood flow was measured to be 0.2 milliliter per gram, not per 100 gram, per gram per minute. So you might be just kind of interested in. Here, our current understanding is here. But previously, the count was here. Anyway, this information is the HMPO K1 and this one. Would it be proportional? Yes. Would it be underestimating? Yes. Because of what? So we need to just think about that. And let me just draw here. In case of, in case of, sorry. Here, you might just find I intended to draw something. So HMPAO and ECD. What's the difference? You might see the tabulated information regarding the difference between HMPAO and ECD in many textbooks. So you don't need memorize that. What you need to memorize is just the HMPAO is taken up in the brain. And actually, HMPAO2, in addition to the brain, lung, liver, brain, the kidneys, and then intestine, and then bladder. The same. In addition to ECD, liver, the intestine and bladder, and kidney here. So it looks the same, and that the hydrophobic, the radiopharmaceutical is taken up in every tissue. Okay, so in case of HMPO in brain, some amount of the injected technetium labeled HMPO is taken up by the brain, but you need to be concerned about the 1 minute, 10 minute, 20 minute, and 30 minutes, the kind of kinetic. I don't know. It's, as I remember, it's like this. This is a back diffusion. Why? Because the HMPO is taken up by the cells. Because these are too hydrophobic. you know, here, this kind of structure is really hydrophobic. And from the standpoint of the HMPO, membrane is not existent. And it's kind of transparent and reach here inside the cell. And inside the cell, there are many glutathione. And glutathione is making HMPO to hydrophilic form. But it takes time, little bit of time. HMPO is entering too much. So HMPO still hydrophobic is back diffused. Why? Single pass, cell is here, blood vessel is here, HMPO is taken up, and blood is again coming. Here, like this, until recirculation is coming. So like this. But HMPO and ECD is too hydrophobic. So it is entering every cell, including brain cell. And then after a while, at first, brain does not have any. This, because of this, brain is like this. So here activity is higher than here. So back diffuse. Why not? If those HMPO in the cells are not going to diffuse back, it should be converted to hydrophilic form. Glutathione is many in every cell, but including brain. But it takes time. So until the glutathione is keeping, and in the blood also there are there are conversion mechanism. I don't know exactly. This is also glutathione, or that's kind of that conversion mechanism is circulating HMPO is going to become hydrophilic, phobic and philic. So that's the reason why we have observed this kind of back diffusion. And then what about the ECD? ECD, same, in a similar way, entered the cell, and then within the cell, what? Esterase. Esterase is changing ECD to hydrophilic form. It's hydrophobic. So esterase is an enzyme. Glutathione is much easy. The glutathione is better to transform, and esterase is an enzyme, so it takes more time. So 10 to 13. So if you just to inject Diamox here, if you inject Diamox, previously 20 years ago, our Japanese colleagues did a test study using blood flow, cerebral blood flow measurement. I forgot, it was a Xenon study or whatever else. Anyway, they have found in Diamox injection here, acetazolamide injection here, Diamox activity according to the PET measurement several times, 10 minutes after, 20 minutes after, 30 minutes after. Diamox activity was like that. No, that way. Activity was higher. So it meant for them, after Diamox injection, when to inject HMPA or ECD. So we do inject, as I remember, HMPA 10 minutes after. Why? Because the Diamox activity was highest. But you know, the ECD take time. So ECD is taken up by the brain cells slowly, then HMPO by what? Esterase activity. Actually, being taken up is similar, but here they don't they experience any this one. Why? Because ECD has this kind of HMPO was this kind of activity. Finally, after 30 minutes, there is no difference between ECD and HMPO. But we are interested in using Diamox activity effect. So that's the reason why we chose HMPAO. And we all know that the ECD is convolution. We used it. Cerebral blood flow convolution, enzymatic activity. That enzymatic activity of esterase is affected by the stroke or an ischemia, that kind of problem. So ECD is not a blood flow agent. ECD is a enzymatic activity has intervened. So that's another reason why we used HMPO. HMPO is a little bit neutral. But as you just see, by just comparing ECD and HMPO, brain ID, percent injected dose, ECD versus HMPO. Okay, I did not mark here, but as I remember, this is ECD and this is HMPO. So percent uptake, ECD is better. That's the one. ECD people are just advertising, but considering all these, if you are going to choose one, just like us, HMPO is better. It's because we are using acetazolamide here, inhibition of carbonic anhydrase here. So brain is producing CO2. All the other tissues, muscle too, CO2, that enzyme is ubiquitous. And if you just kind of cut here, then it is not going to become this ion, and it cannot be moved to other tissues. Why? Because the CO2, the contents of the blood is low. This ion content is high. So if you cut, then in brain, the same CO2 is produced, but CO2 is not converted to transferable ion because of the acetazolamide. Then CO2 pressure is going up. And CO2 is going up, every vessel is dilated. So not just a kind of velocity increase. Velocity is not increased, the same. But vasodilation is the main effect. Vasodilation because of CO2. The main effector is CO2. So as I just told you, HMPO was baseline was already given. Acetazolamide is given, and then 15 minutes after, my memory was wrong, not 10, to 15 minutes after, Hmpa is given, and while the Hmpa study, rest basal study is being done, we inject acetazolamide, and then 15 minutes later we acquire another, but because the technetium half-life is 6 hours, so still there. So the second image is a combination of the resting basal plus diamox. So second image is a combination. So first image should be subtracted from the second one. That subtraction mattered. So in previous days, 20 years ago, we were interested in how to make our subtracted image quality the same as the basal one. So simply speaking, acquire the second image longer or inject a larger amount. So the larger amount or the acquire longer was contemplated and investigated by one of the medical physicists in Korea 20 years ago. And we found that because of this kind of something, that we need to inject how much amount? Not like this paper. These Japanese guys, they have recommended second injection is 33% higher. We did, but second image was so fragmented. So we just did our simulation study, and then finally found, because of this background, we need to inject much larger amount. So finally, we do inject a larger amount or longer. Longer is inconvenient to the patient. Why? Because patients are moving. If we just kind of put the patient in the gantry such a long time, so we injected a larger amount, and finally we could get a very good image like the current images here. Let me show you current image here. Don't you see this would be a similar quality? Acetazolamide stress is actually second image minus first image. This is first image. This has a signal noise ratio of something, but second minus here, signal is still there. Noise is noise 1, noise 2, square root. So signal to noise ratio tends to decrease. So, but we wanted to suit our eyes. The second image has the same quality as the first one. And now you see, we achieved this goal back in 1996 or 7. The medical physicist who solved this problem, they received a PhD degree at that time. We were so happy. We increased the kind of actually intuitively, the increasing the amount of the second injection or the increasing time would might be the solution. Then how much? Why? Because it's radioactivity or it's inconvenience to the patient. So we did. And then finally, after how long years? After such a long year, I could just write down the basal and acetazolamide brain perfusion SPECT in internal carotid artery stenosis here. And this was the first draft was made by the Dr. Wang from Malaysia, and also Dr. Shagera, we call him. We call them the Dr. Tech and Dr. Kai. No, in case of the Dr. Wang, we call him Dr. Wang. And here, the Dr. Kai from Yemen, and our currently fellow at that time, resident, and then Professor Ha, at that time the clinical instructor, and now in another hospital assistant professor. We wrote down this one, and I just let my people to upload this review article just published last year, this year, and whatever. So to write down this one, there should have been two types of information. One is our progress in establishing our imaging and using our images for exactly for the clinical purposes. So how to predict the clinical outcome, and how to assess the intervention. In our case, mainly the bypass surgery. And bypass surgery has two types. One is the synangiosis. Another is the ECIC bypass. It's kind of external and internal. The external and internal. Usually the STA-MCA, superficial temporal artery, is relocated to N2 side to middle cerebral artery. So that's kind of the bypass surgery. Or recently endarterectomy or stenting for neck internal carotid artery. That kind of evolution of the surgical techniques we witnessed, and we helped them to use our technology for kind of objective evaluation of their experience. And thankfully and fortunately, their the effect of their surgery was really good, excellent, in terms of our evaluation, as well as in terms of clinical improvement. Actually, clinical improvement is the best, the best index of improvement. However, we could just kind of a backup, give our backup data, backup evidence of their excellence in improvement. So for almost several decades, they used our technology. So this is the summary. If you just understand the mind of the clinicians, which is detailed in this paper, the first part was totally dedicated to the evolution or changes of the trend of how to use the new surgical technique to help people with internal carotid artery stenosis. In case of moya disease, it's kind of the internal carotid artery stenosis, just at the border of extracranial and intracranial part, which is in the kind of within the saphenous, no, not saphenous. Oh, I forgot the name. So the carotid artery is just kind of has a tortuous course, just entering the internal, the intracranial part. That part is showing the serious, severe chronic stenosis in case of the moya disease, or just atherosclerotic external, the neck area, internal carotid artery stenosis is also observed in the elderly patients, and for those patients, they just kind of translated their success in children, and they are still puzzled why, in case of the elderly, they had not expected that kind of success, but they are, according to their the review articles, which is mainly written by the Japanese and Korean and Chinese authors. I think that this kind of surgery, synangiosis or ECIC bypass or endarterectomy surgery, I think the Korea, Chinese, Japanese, those countries, the neurosurgeons are the best. Why? Because the moyamoya disease has trained at first the Japanese neurosurgeons, and then Korean neurosurgeons, and then finally Chinese neurosurgeons. And you might be interested in the progress, and I have written down. So from the outsider's point of view, and it's a little bit kind of not subjective, objective one. Okay, then I will just kind of summarize within 10 minutes. Here, ischemic stroke for internal carotid artery and cerebral arteries. They need to just decide they are going to do bypass surgery or stenting or endarterectomy, or medical observation. And atherosclerotic, as I just told you, I'm not going to repeat this. And basal and acetazolamide, the Hmpa SPECT, had been used for evaluation of the vascular reserve, and it was successful. And just kind of the same image here. And here, however, you need to be very cautious. And acetazolamide, the infusion, even in acute patients and even in a vulnerable patient just after operation, in our hand, until several years ago, there had been no problem. No casualties, no the side effects. Some kind of a mild side effect was reported in our Korean Society meeting. However, there has been none. And interestingly, because the Seoul National University is doing most cases, the most number of cases, we've experienced this one: acute brain infarction in posterior cerebral artery territory 1 month after surgery on Diamox challenge. And this case was in detail, in depth analyzed once and twice and 3 times. And then our neurosurgeon's view was detailed here, 2017 child's nervous system. And this was the case. First, before first operation, Diamox SPECT was done successfully. And after second, the injection, after the first operation in the left side, and then the patients were waiting for the right side operation. And for right side operation, Diamox was given, and Hmpa was not given. Hmpa was given, but during imaging, patient collapsed, and with resuscitation, we could just kind of save the heart and the lung. However, her brain did not come back. So, and these are the images, and which has shown extensive posterior infarction with the tentorial herniation. So we lost a patient. The patient, after several months, they donated, according to the parents' will, donated several organs to the kind of a transplantation, the waiting patients. and we lost this one. This person, and who is just 16 or 17 years old. Around that time, the Japanese did the same. They experienced the same. Acute pulmonary edema was reported, almost 10 cases per entire period, and they have in a hurry to publish the guideline here, 2015, by the joint effort of the several societies: Japanese Stroke Society, Neurosurgery Society, Neurology Society, and also nuclear medicine. This means that the serious our Japanese colleagues felt about these incidents. And after this one, in elderly male subjects with a poor lung, no, not poor, just with a comorbid disease such as the COPD. The COPD subjects, they were found to have a greater tendency to suffer from acute pulmonary edema, and among those instances, they lost several the patients. So Diamox is not a safe one. So after that, let me just explain here. So after that, extracranial atherosclerotic ICA steno-occlusive disease in the elderly. According to the literature, after a comprehensive review, I found that based on many trials, they have not proven ECIC bypass in these patients to prevent the ipsilateral stroke, or no effect of the endarterectomy over medical treatment. Medical treatment has been improved, and surgical technique was not just kind of selecting the correct patients to have a benefit from the carotid endarterectomy. They just use the anatomical criteria. So our colleagues in the adult neurosurgery, they had a kind of insightful the idea that if they choose the correct person, then they will benefit from their surgery. So they are doing using our the method. However, in case of the intracranial the ICA stenosis, as I just told you, the border of the extracranial and intracranial, that's a supraclinoid portion of ICA. Intracranial moya-moya disease in the young. And the young means, interestingly, there has been an increasing prevalence both in Japan and China and Korea. So we are witnessing, and many more subjects showing the intracranial moya-moya disease in the others. Anyway, moya-moya disease had been known to be a child disease, and according to our the colleagues, mainly in Korea, from Korea or China, recently China, they have reported a huge cohort study. My colleagues in our institution, they have reported the synangiosis surgery in the very young, less than 3 years old. This procedure is risky, but indirect bypass surgery had been helpful. And in children, after this age, definitive benefit with synangiosis surgery. So now they know very well that in very young and also young children, their surgery is going to help and finally they would survive, and they would just have an improved cognitive function. Even they catch up in the school, and they become they became a normal functioning adult. So they were so successful. So because of the tragic incident in a 17-year-old girl in 2015 or 16 in the year, and because they know in every the children, if they are diagnosed as having Moyamoya disease, then everyone is going to improve. Then why use the risky imaging? Even though among almost 10,000 subjects, only one was lost, but they don't want to lose anyone because of imaging. Okay, actually, it's not because of imaging. It's because of the or acetazolamide stress. And we could not understand why that posterior circulation would have shown that kind of impact. Recently, we have made some kind of hypothesis. If it is proven in animal experiment, then I will let you know later on. And then what about the symptomatic adults in adults even with ischemic hemorrhage? Direct EC-IC bypass surgery was found to be helpful. And what about the asymptomatic in the others? In these patients, we are expecting someday the ischemic hemorrhage or uneventful. So there had been a controversy, but recently Samsung Hospital, Seoul Samsung Hospital, our colleagues, they have published their kind of a definitive recommendation that the medical waiting at first, and then while just repeating DIMOX study, and then find out the appropriate period for STA-MCA. It's a direct bypass surgery, and it is the best policy. So I think I really believe, trust the versatility or excellence of the surgical skill, and then peri and post-operative care of these patients by our neurosurgeons all over my country. So according to my understanding, DIMOX SPECT would be a really help. So by just listening to my assertion, what I'm saying is just now you know everything about the clinical indication. During the remaining 10 to 15 minutes, I'm going to tell you about then how to analyze these. Here, the first one is like this. It's kind of a eloquent case. The first one is atherosclerotic. I'm going to expand. That's the first one is here. Okay, you are now seeing the enlarged version here. In the left side, you are seeing the 81-year-old female patient. You are seeing only the gray matter. White matter does not show up. Why? Because the blood flow is 1/3 of the gray matter. The central blue area is not ventricle. It's from white matter. So you are looking at the gray matter here. In basal image, you cannot find asymmetry between left and right, and asymmetry between posterior and anterior. So we say that it's because the patient AZ is high, so patient would show the brain atrophy, related with her age. So images, not like the image from the young. We could see easily that this patient would be older. And then after Diamox infusion, you could see the left side is showing a definitive decrease. To my eyes, we see the left middle cerebral artery territory and left anterior cerebral artery territory, and also here, right anterior cerebral artery territory. And how to define those artery territory? Here, we have this one. That's MCA territory, but individual to individual, there are the ambiguity. What I'm saying is just an individual difference, so one cannot be sure. But anyway, MCA territory is that one, and then ICA territory. Those territory was the territory was defined by our study. During WADA study, ICA cannulation, we injected HMPAO, and we did the data, we acquired data from 20 or more subjects back in 20 years ago by the help of the epilepsy, the epileptologist, the neurologist, epileptologist. They led us to this kind of study. Why? Because they were also interested in the distribution of the HMPAO or sodium amytal during injected during for WADA study. WADA study is just a memory study, and which hemisphere is dominant in maintaining memory, and while just injecting sodium amytal, amobarbital, to the one side, ipsilateral side, and then they did the memory test, task test, and then they find that the hemisphere which is going to be removed is okay for post-operative memory deficit or not. That's the kind of core of the WADA test. And during WADA test, we injected the HMPAO, and we could make a probabilistic atlas of the ICA. And MCA was obtained by Busan, the National University Hospital colleagues. They did a similar one. Middle cerebral artery was one sometimes cannulated for selective angiography, and for those rare patients, they injected their HMPAO and they reported MCA. So ACA was just kind of a subtraction of the MCA from ICA. ACA territory is like that. So I say that right ACA territory is showing a problem. So this case was an extracranial carotid artery stenosis. And in these patients, what are expected from this kind of image and treatment is prevention of stroke and neurological deficit. And then we can help our clinicians to find the appropriate patients and appropriate time. Why? Because in case of asymptomatic case, the kind of routine follow-up, annual or biennial, that kind of, the 2 years apart or 1 year every year, whatever. And medical waiting, not just a medical waiting with a kind of full of O and full of U, no, medical waiting with SPECT. If SPECT, especially after Diamox injection, is normal, then we can say that it's good. Why? Because we reported back in 2005 in stroke. The post-operative moya disease patients were analyzed. Some of them show the remnant remaining the impairment of the vascular reserve in one side, and in that case, in those cases, the patients experienced the more events of the neurological deficit. So to prevent that neurological deficit, we need to we recommend it to our neurosurgeons that they need to find another way to help. And in some of them, their patients, they did redo operation or a combination of the synangiosis or ECIC bypass surgery, especially in the larger, the older older subjects. The right one is moyamoya disease in the young, indirect bypass surgery pre and post. You know, here, left side MCA territory has shown. However, in this case, baseline was also abnormal. After diamox stress, it's a little bit slightly decreased. And interestingly, after bypass operation, both resting and also in this case, the more important one is in this case, the posterior cerebral artery, the territory was also seemed to be affected. We reported it, but without the taking care of the posterior cerebral artery territory here, half of the occipital lobe and also the cortical occipital, half of meaning the midline structure of the cuneus and precuneus, and also the medial and lateral occipital lobes. All those lobes had shown the improvement. So I can just explain every case in very much detail, but I don't think we need to do this again and again. So I'm going to just show you this one. These cases, another case, and I already explained. Finally, I have modified the kind of the pathophysiologic consequences of artery stenosis here by just kind of summarizing every pre-reported concept, and then finally I would comment with this drawing. And previous one was too much simplified. Don't be fooled. It's already published 20 years ago, and it's reproduced without any serious concern. Why? Because they do not have any method to re-evaluate the correct crude concept, which was given the 20 years ago. So I have here the modified. At first, cerebral blood volume is trying to compensate the decrease of the vascular reserve reduction, and then despite volume increase, finally basal perfusion and reserve is permanently, irreversibly impaired. So that's the kind of event of infarction. And before that, everything, every kind of the compensatory mechanism are invited and adapted and are going to be harnessed. And previously, at first, volume compensation and then metabolic compensation. Metabolic compensation is used to be, has been kind of evaluated, investigated and evaluated and assessed by PET. And recently, OEF is being tried to be evaluated by MRI too. I found it interesting. However, the most important one is during hemodynamic insufficiency, the blood volume compensation and OEF compensation is not mutually exclusive. They are overlapped. It's understandable. The people's brain try in every mode, try to survive under the kind of a great challenge of the artery stenosis. So if you are interested in, then please proceed to just follow my drawing. That's my own drawing with the help of the Dr. Ha. Okay. And then I'll move on here. This is two. So this is the final last slide. I'm going to save 10 minutes for the concept using using basal cerebral blood volume and mean transit time instead of the measurement of the vascular reserve. There have been many reports. I would say, finally, not possible by basal perfusion MRI. You know, that's my the bias. However, in the MRI journal, every time they are saying that the basal perfusion MRI, if they do the kind of meticulous analysis, they can just kind of take over the Hmpa SPECT using perfusion MRI. And on the left side, we just summarize that. How can it just kind of that's kind of a basic facts. And here, almost 10 years ago, I could successfully persuade that our radiologists should do the diamox MRI. Here, arterial spin labeling is a technique to do the perfusion study here. Dr. Yun reported in radiology that their image almost mimicked basal and stress SPECT here, right? M-shaped. Okay. But do you see really similar, or sometimes it's a little bit different? Okay, you might just enjoy the image. And then what about this? Pre and post, almost similar. Okay. However, post in our image, the basal and stress is the same as the normal. However, in case of the ASL, it's improved, but a little bit different from ours. Then please be reminded that arterial spin labeling is mainly interested in visualizing what? At best, velocity. We are looking at flow. Why? The Hmpa doesn't discriminate velocity and area. Brain is known to show increased blood flow by increasing blood volume or area, or they call it capillary recruitment. Some of the capillaries are closed during resting basal period, and once some portion of brain is activated, then blocked capillaries are becoming patent, meaning increasing blood volume, and then meaning increased blood flow. Those increased blood flow is represented by Hmpa and ECD. But you know, the arterial spin labeling is spins are labeled within the blood vessel, the blood in the blood vessel, and then they do just follow that spins move moving to the periphery. So that's the difference between MRI and SPECT. Our colleagues know that, and our colleagues are not doing any more diamond SPECT. Why? Because around that time they published, and they were really happy with the publication for the first time in the world in radiology journal, and then they stopped. Why? Because we lost one subject here, and they heard, and they could not bear that kind of loss. So they are doing not diamox perfusion MRI. They are doing just kind of a resting perfusion MRI, and they are still trying very hard to replace diamox challenge with meticulous, versatile, and refined, the improved, whatever it is called, the analysis method. That's their dream. So we are looking at physiology. They are looking at methodology. Interestingly, we have best medical physicists. They don't have physicists. So the Seoul National University Hospital was a pioneer in doing diamox SPECT, the ASL MRI, but they don't have physicists to help them. So that's this real last image, last slide is our, oh yeah, I have put the wrong RYOO. Dr. Liu had published after analyzing 7,000 images of 4,000 cases, and used deep learning or artificial intelligence to let the machine to read our images in our stead. Why? Because these days we have only one resident per country. The national insurance system, they have set their mind to ruin the excessive growth of the nuclear medicine clinical practice. We have only 300 nuclear medicine physicians, and all over the country, 70 or 100 according to how we define the nuclear medicine department. Anyway, 70 institutions and 300, but some of them are not doing nuclear medicine. So just to say 150 or 200 nuclear medicine physicians are working, and we are doing 1 million cases per year. The Japanese are doing much more, and 2 million cases, and Chinese are doing 3 million cases. 2 million, okay. All over the CJK, we are doing 5 million cases. But interestingly, that kind of the clinical volume were found to be excessive from the eyes of the regulators, and they set a bizarre and weird kind of indication setting from the national insurance system. So they almost annoy clinicians to explain why they are just sending their patients to nuclear medicine. So that has kind of just kind of raised the grim prospect of the job, the allocation, job kind of seeking. So our future, the nuclear medicine physicians, next generations are not coming. So many. So we have 20 slots per year. Last year we filled 2 slots. So it is going to make the nuclear medicine board persons so I can say what I can say, so valuable. So every institution is trying very hard to invite anyone So the hospital directors are complaining, but the person in charge who destroyed temporarily the future of the nuclear medicine in my country, he would have been promoted to the next position. That's kind of irony. So we are doing, so that's the reason why we try to learn, teach artificial intelligence to take our job. If they do their job, then we are kind of supervising our the reading by our the machines. Okay. Now I'm going to invite any the policy issues and then prospect issues or technical issues. Dr. Gill, do you have any question? Dr. Asmal, do you have any question? Just like previous week, because I used another 10 minutes to explain the current situation of nuclear medicine of Korea. So I'm going to use injury time if needed. If not, then I can just kind of stop. Dr. Gill, you have the privilege to ask question, and Dr. Asmal, you're the next, and Dr. Hien, and Dr. Tong, and Dr. Rahab, Alexander. Okay, anybody? Dr. Win? Okay, Dr. Gill, you're the first. And then young colleagues from Hassan Sadikin and young colleagues from the Pak Mai. Soo Tet-o, nice to see your name again. Dr. Gill?
Yeah.
Yeah, so you know everything. Okay. Or you have been overwhelmed. Oh. So I think I need to solve your technical problem. You in the reading room, and it is just kind of a howling. Okay, you know, I'm the person who is taking care of technical problems with our computer manager, Mr. Kim. Then Dr. Asmal first. Do you have any question? Or comment, please. Once you arrive here, second. Oh, what's wrong? 김동빈 씨, 이거 뭐가 잘못된 거예요? 왜 하울링이 전부 돼? 몽땅 하울링이 되는 이유가 뭘까요?
하울링 되는 게 아니고요. 어떤 분이 마이크를 계속 켜가지고, 네.
근데 전체 켠 건 아니잖아요.
네, 근데 그쪽 분이 두 개의 장치로 연결을 한 것 같은데요.
Yeah. So let me just tell you, if you have two systems in the same room, if you turn on your microphone, and if you do not just kind of turn off speaker of one system, then it is going to be sure. So it's not howling between centers, it's howling within your center. So if you have actually I'm using two systems. One is a television monitor to show your names, and another is my notebook to show you my PowerPoint slide. So somebody asked me, Dr. Charisma, is there any special preparation for Dimox test? Dimox test, is there any special preparation? Dr. Gill, would you answer? Is there any special preparation for Dimox test?
No, there isn't there isn't special preparation for diagnosis.
No, so what I'm saying is just what he's saying is there is no the pre treatment. What I mean is no NPO, no the abstinence of the caffeine, so no anything, nothing. However, I know what Dr. Charisma is asking should have meant that among the 10,000 cases, actually in my institution, 10,000 cases per the entire 25 years, we lost to one patient, but our Japanese colleagues, they are doing 10,000 cases per year. Last 10 years, they have done 100,000 cases, and they have the risky patients. They have found the risky patients, which who are, as I explained, old age, smoking, the male patients, male subjects, and comorbidity with the COPD, chronic obstructive pulmonary disease. Those kind of persons are showing. Interestingly, they have interpreted its anaphylaxis. But if it is going to be anaphylaxis, that then they would have shown not just idiosyncrasy, but just kind of anaphylaxis. They would have shown it's immune mediated, but I don't think they have, as according to the clinical features, they could. It's kind of exclusion, the one, and for us, after the detailed and deep the analysis by myself, my analysis was an independent one. So after that instant, I collected all the data and the reports, and also interview with every person. Finally, I concluded that this case would have been prevented. If the protocol would have been a little bit flexible. Since 25 years ago, our child neurosurgeons, they have established a protocol. Once patient arrive, they are going to be evaluated with SPECT in all patients, and there have been the uneventful. And then after one side operation, they have two operations. One, the worst hemisphere first, and then finally better hemisphere. But in this case, bilateral internal carotid artery and also bilateral posterior cerebral artery were involved. However, that kind of patients we've experienced a lot. So they were a little bit they did not have any concern. So according to the protocol, they just to kind of after one side, after operation in one side, they routinely send their patients for evaluation of the improvement of the first operation, and then do the second operation. But in this case, patients were so severe, so the second operation was scheduled just 2 months after. So interestingly, previously they did not send their patient so early after operation, that 1 month after operation, around 1 month, very early, and patients looked good. the patient arrived from outpatient, not inpatient. So she walked in and she lied down with deep coma, and then in ICU for several months later, several months. So after this incident, after the scrutiny, I recommended to my colleagues, surgeon colleagues, that please don't do the second, the interim evaluation. In other patients, usually one side operation first, and then follow-up study was scheduled 3 months or 6 months later. And then second operation would have been done 1 year later from the first operation. So that was the protocol, but that protocol was squeezed. And according to the protocol, the doctors in the ward, they sent the patient. Doctors in the ward before discharge, they have scheduled the follow-up study, and that kind of study. Why that kind of study was planned? It's because we have done a 1 week after study in a cohort of patients to reveal the meaning of the hyperperfusion syndrome of ECIC bypass or the Shinanjoshi surgery. So in those cohort group, there have been no problem. So 1 week after is okay. So 1 month after would be okay, but not the case in that patient. So is there any special preparation? Is just kind of a meticulous decision. Please don't do the kind of a strict. 3 months after is okay for every patient. Does not mean 1 week after a study is okay, or 1 month the study is okay. So according to the anatomy of the posterior circulation, our neurosurgeons, they are very good at anatomy evaluation. So this is my detailed opinion, but it is not published, and it is just kind of, it is not, this idea is not peer reviewed, and this idea was did not reach any consensus. So consensus is reported in the literature. So anyway, they have stopped. The Chong et al. 2017 Charles nervous system. And at the conclusion, they said they are not going to do the Diamond SPECT in children anymore. And they are going to do just a resting state perfusion MRI. If perfusion MRI does not give us the sufficient information, it's okay. Why? Because in every patient, the surgery has been proven to be effective in terms of the clinical outcome and also the quantitative Diamond SPECT study. There is a conclusion. Okay, Dr. Asmal and Dr. Gill, again, you have. Thank you, Dr. Charisma. You have raised the really important point. Okay. Dr. Asmal and Dr. Gill, do you have any more? Okay, then we can just move on. Next week, a little bit more kind of difficult to understand. However, I'm going to make the next week's presentation as simpler as possible, or if not, I'm going to just summarize the, not take-home message, take memory message. So if you cannot understand very well, then just memorize it. Okay, then getting familiar with the notion of the tracer kinetic. And then you might just kind of find after a while, you might just feel comfortable with those concepts. And those concepts are ours. not the clinicians. So it's unique. And our clinicians are really going to be dependent upon, they had become dependent upon us. And your colleagues are going to depend upon you. Then your expertise, your career would be a success. So we'll be is a little bit, we are pursuing a little bit the diverse and easier discipline, in my opinion. Why? Because we take care of clinicians, our colleagues, instead of the patients. Patients are the most important. So if our patients feel a little bit not satisfactory, then it is immediately going to be a problem. But our clinicians, they can just wait for our move. So I would have been, I can say that I was successful in making a communication with our colleagues. This was a continuation of Professor Myung-Chul Lee's work, and I enjoyed a lot with it, except for one subject. Okay, thank you.